Every single week, I see the same gut-wrenching scenario unfold in the emergency room. A stretcher races through the double doors, carrying someone whose life has just been shattered. They're often middle-aged, sometimes even younger. Their families, faces etched with terror, tell us the same story. But her doctor just said she was fine. Just 3 months ago, he told her everything was perfect. And now, she's here. A stroke, permanent damage, a life irrevocably changed. My heart sinks every single time because I know that in far too many of these cases, this tragedy could have been predicted. It could have been prevented. The warning signs were there, but the standard tests simply weren't looking for them. And today I'm begging you, with all my professional experience, to get one specific test done. A test that could uncover your true risk and save you from becoming another devastating statistic. The truth is, stories like hers, stories of apparent wellness giving way to sudden, devastating health crises, are far more common than any of us want to admit. And for me, as a physician who has witnessed the aftermath firsthand, who has stood beside terrified families in the ICU, it's not just a statistic. It's a deeply frustrating, often preventable tragedy. It's a wound that medicine, despite all its advancements, sometimes inflicts through omission rather than commission. Most people believe implicitly in the annual checkup. We're conditioned from a young age to trust the process, the blood pressure cuff, the stethoscope, the standard blood panel. And when the doctor, after reviewing those routine results, confidently says, "Everything looks good, you're fine," there's a profound, almost primal sense of relief. We walk out of that office feeling secure, validated, almost invincible. We mentally tick off health from our to-do list for another year. But what if fine isn't actually fine? What if those routine tests, the very bedrock of our preventative health screenings, are consistently missing the early, subtle warning signs of a ticking time bomb inside your body? What if the tools we've relied on for decades are, in some critical ways, outdated, leaving millions vulnerable to events that could be predicted and potentially prevented? This isn't about casting blame on individual doctors. It's about a systemic gap in conventional screening, a persistent blind spot that, despite overwhelming scientific evidence and countless patient outcomes, it remains tragically unaddressed in many primary care settings. The problem isn't malice, it's inertia, deeply embedded historical practices, and a lack of widespread education on newer, more precise markers of risk. The standard lipid panel, the total cholesterol, LDL, HDL, triglycerides, these are the familiar markers we all know. They are important. Don't misunderstand me. They tell us about the amount or concentration of fatty substances in your blood. A high total cholesterol or high LDL-C is certainly a red flag. But, and this is the crucial distinction, they don't tell us about the nature of that fat, or, more critically, the true risk of it causing the kind of catastrophic event, a stroke, a heart attack that ripped that woman's life apart just 3 months after she was told she was fine. Let's use an analogy that helps visualize this critical difference. Imagine a busy city, and your blood vessels are the main arteries and highways connecting everything. The standard lipid panel tells you how much cargo, cholesterol, is being transported through that city. A high amount of cargo might suggest a busy city, perhaps even congestion. But what it absolutely does not tell you is what kind of vehicles are carrying that cargo. Are they small, nimble motorcycles easily weaving through traffic? Or are they massive, overloaded, aggressive trucks, causing damage and prone to crashing, spilling their contents? It doesn't tell you if those vehicles are speeding, driving on the wrong side of the road, or if their brakes are failing. That, precisely, is the critical missing piece of information. For decades, medical science has focused almost exclusively on LDL cholesterol, often dubbed the bad cholesterol. The mantra has been, lower your LDL and your risk of cardiovascular disease goes down. And yes, broadly speaking, This is true. Reducing LDL-C is a foundational strategy for cardiovascular prevention. However, what we've learned through extensive, rigorous research, through meticulous population studies, and tragically, through countless patient outcomes, like the one that introduced this discussion, is that LDL cholesterol itself isn't the whole story. The number of LDL particles, and more specifically, the type and size of those particles, is often a far more accurate, nuanced, and, frankly, a life-saving predictor of cardiovascular events like strokes and heart attacks. This brings me directly to the test I am not just recommending, but unequivocally begging you to get done, the ApoB test, or apolipoprotein B. Let's dissect what ApoB is, why it holds such profound significance, and why its routine omission from standard panels is, in my professional opinion, one of the most glaring and dangerous blind spots in modern preventative cardiology. ApoB is more than just another number on a lab report. It's a specialized protein that resides on the surface of every single bad cholesterol particle. Think of it as a unique, non-negotiable ID badge or a tracking device. And every single particle that has the potential to contribute to the insidious process of plaque formation within your arteries. These are primarily low-density lipoproteins, LDL, but also very low-density lipoproteins, VLDL, intermediate-density lipoproteins, IDL, and a particularly pernicious particle called lipoprotein A, or LPA. Each and every one of these atherogenic, plaque-forming particles carries exactly one ApoB molecule. Therefore, by simply measuring the concentration of ApoB in your blood, we're not just measuring the total amount of cholesterol inside these potentially dangerous particles. We are directly measuring the actual count of those particles circulating in your bloodstream. It's like counting the individual trucks on the highway, rather than just estimating the total tonnage of cargo they collectively carry. Why does the number of particles matter more than the amount of cholesterol they contain? Let's return to our city highway analogy. It's not just the volume of cargo being transported that causes a catastrophic pileup. It's the sheer number of individual vehicles on the road, particularly the ones that are prone to collision or breakdown. Each one of those lipoprotein particles, regardless of how much cholesterol it's carrying at any given moment, has the inherent physical potential to penetrate the delicate inner lining of your arterial wall. Once it breaches this protective barrier, it can get trapped within the artery's inner layer, where it becomes oxidized and ignites a cascade of inflammatory responses. This initiates and fuels the slow, silent, relentless process of plaque buildup, atherosclerosis. This plaque over years accumulates, hardens, narrows your arteries, making them stiff and less flexible. Critically, these plaques can also become unstable, rupture, and trigger the formation of a blood clot that completely blocks the artery, leading directly to a heart attack if in the coronaries, or, as in the tragic case we started with, a stroke if in the cerebral arteries. So, here's the insidious scenario that often plays out. You could have a seemingly normal or even low LDL cholesterol reading on a standard lipid panel. Many doctors would look at that and say, "Great, your bad cholesterol is low, you're at minimal risk." But if your ApoB count is high, it means that despite the low concentration of cholesterol, you actually have a very high number of these dangerous, plaque-forming particles coursing through your veins. This specific and perilous situation is known as discordance, and it is frighteningly common. Imagine someone with an LDL-C of 90 milligrams per deciliter, which is often considered optimal. But because their particles are very small and dense, they could have an ApoB level that suggests they actually have the same number of particles as someone with an LDL-C of 130 milligrams per deciliter, which is considered elevated. In this discordant scenario, the low LDL-C gives a false sense of security, while the high ApoB reveals the true, elevated risk of future cardiovascular events. Your doctor says you're fine, you feel fine, but internally, silently, your risk for a stroke or heart attack is escalating with every beat of your heart, completely unnoticed by standard screening. This is the hidden reality. And it's the diagnostic blind spot that directly leads to those devastating headlines. Healthy person drops dead, or she was fine, then a stroke. The patient whose routine labs look good, whose lifestyle appears healthy, but whose ApoB level tells a completely different, far more alarming story about their inherent risk. It's a silent biochemical threat that the standard panel, with its focus purely on cholesterol mass, simply isn't designed or equipped to catch. The weight of evidence. Why ApoB's superiority isn't new news. This isn't some fringe theory or experimental marker. The scientific community has been aware of ApoB's superior predictive power for decades. Numerous large-scale prospective cohort studies involving hundreds of thousands of participants followed over many years and have consistently demonstrated that ApoB is a more powerful and reliable predictor of future cardiovascular events than any of the standard lipid metrics, including LDL-C. Consider the landmark Inner Heart study, which identified 9 modifiable risk factors accounting for over 90% of the risk for acute myocardial infarction, heart attack. Even within this comprehensive analysis, the ratios involving ApoB emerged as particularly strong predictors. Or look at the Framingham Heart Study, a cornerstone of cardiovascular epidemiology, which has consistently shown the added value of particle-based measurements. Meta-analyses, which combine data from multiple studies, have further solidified ApoB's position as a robust, independent, and arguably the most robust lipid-related risk marker. It cuts through the noise and provides a clear signal. For example, a hypothetical patient with an LDL-C of 100 milligrams per deciliter and an ApoB of 120 milligrams per deciliter would be at significantly higher risk than a patient with an LDL-C of 100 milligrams per deciliter and an ApoB of 80 milligrams per deciliter. The number of damaging particles is different, even though the mass of cholesterol is the same. The standard panel would treat these two patients identically. An ApoB test would reveal the critical disparity in their true risk. Why the slow adoption? A look at systemic inertia. If ApoB is so important, if the evidence is so compelling, why isn't it standard? This is a complex, multifaceted question, rooted in the sometimes frustrating reality of medical practice and innovation. 1. Historical precedent. Medicine, like any large institution, is resistant to change. The standard lipid panel has been ingrained in practice for decades. It's what doctors learned in medical school, what's in every textbook, and what insurance companies have traditionally reimbursed. 2. Cost and reimbursement. While the cost of an ApoB test is relatively modest, often 20 to 50, sometimes less, the cumulative cost across millions of patients can seem daunting to healthcare systems. Furthermore, obtaining insurance reimbursement for tests not considered standard of care can be challenging, leading many physicians to avoid ordering them to prevent patient out-of-pocket expenses or administrative headaches. 3. Lack of education. Medical education, especially for primary care physicians, often prioritizes breadth over depth. While cardiologists are increasingly aware of advanced lipid testing, this knowledge hasn't fully permeated general practice. Many busy primary care doctors simply haven't been adequately trained or updated on the clinical utility and interpretation of ApoB4. What will I do differently? Mentality. Some practitioners might argue, if LDL is high, I treat it. If ApoB is high, I'd still treat it similarly. So, why bother with the extra test? This viewpoint misses the critical point of discordance. It misses the patient with normal LDL who is actually at high risk, or the patient whose LDL has been lowered by medication, but their ApoB hasn't responded as robustly, indicating a need for a different therapeutic approach. 5. Perceived complexity. Interpreting particle numbers can sometimes feel more complex than simple cholesterol mass for physicians who are not specialized in lipidology. But the science is clear, and the tide is slowly turning. Leading cardiovascular organizations, recognizing the weight of evidence, are increasingly advocating for the inclusion of ApoB in advanced risk assessments, especially for those at intermediate or high risk, or those with a family history. Many forward-thinking clinicians, particularly those specializing in prevention or integrative medicine, are already incorporating it into their routine practice, unwilling to leave their patients vulnerable to these preventable outcomes. What does a high ApoB mean? And more importantly, what can you do about it? If your ApoB comes back elevated, it's a clear, unambiguous signal that you have an unacceptably high number of these dangerous, plaque-forming particles circulating in your bloodstream. This unequivocally means your risk of developing and progressing atherosclerosis, and thus your risk of suffering a future stroke or heart attack is significantly higher than what a standard lipid panel might suggest, even if your LDL-C looks perfectly normal. The good news, and this is crucial, is that we absolutely know how to address high ApoB. The strategies are often similar to those for high LDL cholesterol, but with a more targeted, precise, and informed approach, driven by the clearer objective that ApoB provides. We are no longer just guessing, we have a direct count of the enemy particles. Here's a multifaceted approach to lowering your ApoB and significantly mitigating your cardiovascular risk. 1. Dietary interventions, a foundation of health, focus on whole, unprocessed foods. This is paramount. A diet rich in foods in their natural state. Fresh fruits, vegetables, whole grains like oats, quinoa, brown rice, legumes, lean proteins, and healthy fats is foundational. These foods are typically high in fiber, antioxidants, and beneficial phytonutrients, all of which support healthy lipid metabolism and reduce inflammation. Minimize refined carbohydrates and added sugars. This is perhaps the single most impactful dietary change for many. Refined carbohydrates, white bread, pasta, pastries, and especially added sugars, sodas, juices, sweets, many processed foods, are notorious for increasing the production of VLDL particles in the liver. Remember, VLDL particles also carry an ApoB molecule. Reducing these rapidly absorbed carbohydrates reduces the liver's stimulus to pump out more atherogenic particles. Read labels rigorously. Sugar hides everywhere. Prioritize healthy fats. Not all fats are created equal. Incorporate abundant sources of monounsaturated fats, extra virgin olive oil, avocados, nuts like almonds and pecans, and omega-3 fatty acids, fatty fish like salmon, mackerel, sardines, flax seeds, chia seeds. These fats support healthy cholesterol profiles, reduce inflammation, and can improve particle size and number. Avoid trans fats completely, found in many processed, fried, and baked goods, and limit excessive saturated fats, red meat, full-fat dairy, some tropical oils, as these can increase ApoB for many individuals. Increase soluble fiber. Foods like oats, barley, apples, pears, beans, and psyllium husk are rich in soluble fiber. Soluble fiber binds to cholesterol in the digestive tract, preventing its reabsorption and prompting the liver to pull more cholesterol from the blood, which can indirectly reduce ApoB levels. 2. Lifestyle modifications, empowering your body's natural defenses. Regular physical activity. This is non-negotiable. Aim for at least 150 minutes of moderate intensity aerobic exercise per week, brisk walking, cycling, swimming, or 75 minutes of vigorous activity. Additionally, incorporate strength training 2 to 3 times per week. Exercise not only improves overall cardiovascular health and weight management, but also directly influences lipid metabolism, improving insulin sensitivity, and potentially altering lipoprotein particle size and number. Maintain a healthy weight. Excess body fat, particularly visceral fat, around the abdomen, is metabolically active and can significantly contribute to insulin resistance, inflammation, and increased production of ApoB-carrying particles by the liver. Even modest weight loss, 5 to 10% of body weight, can yield substantial improvements in ApoB and overall cardiometabolic health. Quit smoking. This is probably the single most impactful lifestyle change a smoker can make for their cardiovascular health. Smoking profoundly damages the endothelial lining of blood vessels, making them more permeable and susceptible to particle penetration, and significantly worsens lipid profiles. Manage stress. Chronic stress triggers a cascade of hormonal responses, for example, elevated cortisol, that can negatively impact blood sugar, insulin sensitivity, blood pressure, and lipid profiles, indirectly influencing ApoB. Incorporate stress reduction techniques such as meditation, yoga, deep breathing exercises, spending time in nature, or engaging in hobbies. Prioritize quality sleep. Poor sleep quantity or quality, less than 7 to 9 hours per night, or fragmented sleep, is linked to increased inflammation, insulin resistance, and adverse lipid profiles. Establish a consistent sleep schedule and optimize your sleep environment. 3. Pharmacological interventions, if necessary. When lifestyle needs a boost. For some individuals, even with diligent dietary and lifestyle changes, ApoB levels may remain elevated due to genetic predisposition or other underlying factors. In these cases, medication becomes a vital tool. Statins. These are the most common and often first-line medications. Statins work primarily by inhibiting a key enzyme in cholesterol production in the liver, which leads to the liver upregulating LDL receptors. This effectively pulls more LDL and other ApoB-carrying particles out of the bloodstream, directly lowering ApoB-ezetimibe. This medication works by inhibiting cholesterol absorption in the gut. Often used in combination with statins, it provides an additional mechanism to lower circulating ApoB levels. P-thiazide SK9 inhibitors. These are powerful injectable medications, for example, evolocumab, alirocumab, that prevent the breakdown of LDL receptors on liver cells, leading to a dramatic increase in the removal of ApoB-carrying particles from the blood. They are typically reserved for individuals with very high ApoB genetic conditions, like familial hypercholesterolemia, or those who cannot tolerate statins. Fibrates. While primarily used for high triglycerides, some fibrates can also impact ApoB, particularly by affecting VLDL metabolism. Omega-3 fatty acid prescriptions. High-dose, prescription-grade omega-3 fatty acids, icosapent ethyl, have shown significant benefits in reducing cardiovascular events in patients with elevated triglycerides and can also contribute to lowering ApoB. The key here, and this is where ApoB truly shines, is that if you do need medication, an ApoB measurement gives us a much clearer, more precise target. We are no longer just aiming to reduce cholesterol mass. We are aiming to reduce the actual number of dangerous particles. This allows us to monitor treatment effectiveness with far greater accuracy. We know if the number of vehicles on the highway is truly going down to a safe level, rather than just guessing based on the total cargo. This enables truly personalized medicine. My urgent plea: take control of your health narrative. Here's my absolute, unequivocal plea to you. Don't wait for a crisis to understand your true risk. Don't simply accept "fine" as an answer if you have any lingering concerns about your cardiovascular health, if you have a family history of heart disease or stroke, especially at younger ages, or if you simply want the most accurate, comprehensive picture of your own unique risk profile. Ask your doctor for an ApoB test explicitly. It is a simple blood test. It's typically done after a 10 to 12 hour fast, just like a standard lipid panel. It is readily available in most commercial labs. If your doctor is unfamiliar with it or dismisses its importance, do not be deterred. This isn't a confrontational request, it's an informed one. You're advocating for your own health. I armed with evidence. What to say to your doctor? Doctor, I've been researching advanced cardiovascular risk assessment, and I'm very interested in getting an apolipoprotein B, ApoB test. I understand it provides a more accurate measure of the number of atherogenic particles in my blood than a standard LDL-C, especially given the potential for discordance. I'd like to understand my true risk more comprehensively. If they still hesitate, politely inquire about their rationale. If they suggest it's unnecessary or not covered by insurance, you can offer to pay out of pocket. It's often a small price for such critical information. If you encounter persistent resistance, it may be time to seek a second opinion from a cardiologist or an integrative medicine physician who is demonstrably up to date on advanced lipid testing and preventative cardiology. Your life is too valuable to be left to outdated screening protocols. This isn't about fear-mongering. It's about empowering you with knowledge. It's about giving you the most complete, accurate information about your body so you can make truly informed, proactive decisions to protect your heart, your brain, your future, and your quality of life. Don't let a silent, preventable risk become a devastating, life-altering reality for you or your loved ones. Get this one test done. It could be the difference between fine and truly thriving.